Hello, today we're going to talk about the use of cone beam computer tomography in endodontics. CBCTs started to become a lot more popular in endo around 2010, and they actually created a paradigm shift in diagnosis, treatment planning, and treatment in endodontics. A lot of the times when we are playing a guessing game, we weren't sure what was happening. CBCT came in very handy to help us figure out things. They don't do magic. They don't show us everything. But as time goes by and the machines, or went by, the machines got more precise, and clinicians learned how to interpret the data or the volumes a lot better, and there is more evidence also helping how to interpret the images in a more efficient way. And not only the machines got better, but the softwares also were improved immensely. The American Association of Endodontics put together Colleagues for Excellence newsletter in the spring of 2018, and they discussed the impact of cone beam computer tomography in endodontics, a new era in diagnosis and treatment planning. They didn't include treatment, but definitely during treatment, a CBCT scan can be needed. In endodontics, radiographs are the most popular method of imaging. However, they are a 2D representation of a 3D image. They can present with some anatomical noise and distortions. They're still the primary imaging for endodontics. However, they do have their shortcomings. When we're taking a cone beam computer tomography, CBCT, the X-ray source that we're using for the imaging is directed at the area of interest, and the X-ray source is then rotated during the exposure and will generate a 3D image. The way the X-ray source is rotated, we'll create a cone, shape of a cone. That's what we see there on the diagram. That's why it's called a cone beam computer tomography. When we look at a 2D image on a computer screen, these images are built with pixels. A voxel is a 3D pixel. So we have there on the top of the screen on the left side, we have the picture of a pixel. It's very flat, and the picture of voxel is more 3D. So for volumes, pixels are the units that build the volumes. The voxel is a very important unit. Of course, this is how the images are going to be built, but also the voxel will provide the image resolution. And in endodontics, we want small voxel sizes. The smaller the voxel size, the higher the resolution. So in endo, if you think that we are looking for calcified canals, such as, or any calcified canal for that matter, or small canals such as MB2, or small resorptive lesions on teeth, then we need resolution. It's different of ICADs or even CBCTs for that matter for oral surgery, where they're looking at nerve bundles, where they're looking at bone fractures. They don't need the same resolution. Just showing again in this diagram here, the difference between a cone beam, where there's that cone shape because the X-ray source is rotating as the machine is working to capture the image, and then the image on the top, it's not rotating. It's sort of a fan of X-rays instead of a cone of X-rays. So the difference of during the acquisition of the image. This is an older table from 2009, and it talks about voxel size and the details of machines currently on the market. This is 11 years old, but I just want you to have an idea of how different machines will have different voxel sizes. So if you go, for instance, to the Plan Mecha, which is one on the very top, we'll see here that the native voxel size in microns is 0.16. If we go, for instance, to the Carestream Kodak 9000, the voxel size is about half of that. So definitely the Carestream is going to have a much better resolution for endodontics compared to the Plan Mecha. The Cavo OP3D is the one here at the bottom that I added to the bottom of the table because this is the machine that we have here at the school, and the voxel size is 0.085, which is one of the smallest in the market. Just to notice the difference when we talk about voxel size, both images were taken from the same mandible. So the image on the left, but they were taken with two different machines with two different voxel sizes. So image on the left, the voxel size is 0.4 millimeters, and the voxel size on the right is 0.16, so much smaller than about a third of the size of the one on the left. So look at how much detail we can see. On the image, we can see two teeth here. We can see more of the bone trabecula here. And on the image on the left, we can now we can see that this is the tooth and this is the tooth because we saw the image on the right. But if you only had the image on the left and you're not very proficient at looking at these images, you wouldn't know that these are teeth. So this one on the right, apologize for that. The one on the right has much more detail than the one on the left. When we're looking at these images, they are 3D images. So we have to be familiar with the viewing planes when we are looking at these images. We can look at viewing planes separately, but we can also build a volume out of the viewing planes. So there's 3 viewing planes. There's the coronal plane, that's from front to back. There's the axial plane, that's from top to bottom. And the sagittal plane, which is side to side. So the combination of these 3 planes, with the combination of the 3 planes, we can build a 3D image. However, when we are looking at these images, we look at one plane at a time, and we are reading each plane and gathering the information. In 2015, the American Association of Endodontists and the American Association of Oral Maxillofacial Radiologists put together a joint position statement in terms of the use of cone beam computed tomography in endodontics. It was actually an update. They had one, but it wasn't it wasn't as comprehensive, of course, because they didn't have the same knowledge back then that they had in 2015. And it wasn't as popular either, the first version. So this one was more comprehensive and it was more disseminated. A lot more people knew about it, and a lot more people could use it as guidelines. The way that they structured this document, they looked at 3 major categories. One was the volume size, that we discussed how important it is in endo already, or voxel size, sorry. This is volume size. Volume size and field of view, because they are kind of tied up together. Those considerations, and the third one, interpretation. So let's start with field of view. And the acronym is FOV. So the field of view can be small, medium, or large. And in endodontics, we only use small field of view volumes. The reason, there's different reasons. We're going to talk about it, but let's compare. In endodontics, our primary imaging is periapical radiographs. So if you look at the image on the left, which is a periapical radiograph, and look at the image on the right, which is a sagittal view in a CBCT scan, you will see that they captured more or less the same structures. So as dentists, we are very versed in interpreting periapical radiographs. If we take a small field of view, or any CBCT scan, regardless of the field of view, we are responsible for reading and interpreting the image in its entirety. If you're not capable or trained to do that, then we have to send that image to an orofacial maxillaradiologist for reading of these images. However, if we are limiting the field of view to small, there is a very good chance, and of course maybe at the beginning when we are learning we may need some extra help, but we may be able to read the image properly most of the time. So the image on the right and the image on the left are of the same teeth. You see that the CBCT scan is kind of flipped, and this is the way the image is. So it's quad 4, so the 4, 5, 4, 6, 4, 7, and same teeth on the right on the CBCT. So the differences that we're noticing here in the furcation area of 4, 6, you see that there's a fuzzy area on the bone that we can clearly see that there is an area of low density or a radiolucent area in the furcation area and along the roots in tooth 4, 6. The second one that we have to consider is dose considerations. We always have to follow ALERA principles. In order to do that, the smallest possible field of view will expose the patient to less radiation. So we already talked about being able or proficient at reading the image. Small field of view would be much easier, and a small field of view will also expose the patient to less radiation. The smallest voxel size is the best because we want to capture enough detail to be able to identify the things that we want to identify on a CBCT scan. It will also give us a better resolution, and for most machines, the small field of view, or the smallest voxel size rather, will be the default for a small field of view images, because the machine understands if you're looking at a smaller image or a smaller field of view, you want detail. The lowest milliampere settings will also depend on the patient size, but the machine you can, most of the machines are pre-programmed already the same way with the X-ray machine that you select adult or child, and it will expose the patient to lower radiations. The shortest exposure time will expose the patient to less radiation. And the machines can have a post or a continuous exposure mode of acquisition of the image, and the post one will expose the patient to less radiation. So if these are things that you have to understand and know if you're planning on buying a CBCT scan machine. The other thing about those considerations, and again, this is an older table from 2009, is that patients may be concerned about radiation exposure, but some patients may be very tentative or hesitant, rather, to have a CBCT scan taken because they are thinking about radiation exposure. So things that we have to discuss with the patient. First of all, some patients are okay with that, but some patients need to be educated on the principles of radiation and understand that there is radiation in daily life, and that we're exposed to it every day. We also have to explain to them the amount of radiation that they are going to be exposed if we're taking an x-ray or if we're taking a Cbct scan. So let's look at the table together here, where we see that there is activity and different types of imaging there. Some of them are periapical radiographs, or bite wings, and Cbcts, and there is ICATs, and medical grade x-rays there, and CTs, and the effective dose in microsieverts. So in one day, the background radiation at sea level is 78 microsieverts, and one digital PA radiograph exposed the patient to around 6 microsieverts of radiation. So about the same thing that we are, same amount of radiation we're exposed in a day. Now let's look at the Cbcts here and go to Kodak focused field, which is the small field of view. It's called a small field of view or focus field of view in an interior area. Of course, we're looking at density of bone. The more dense the bone, the denser the bone, the more radiation the patient will be exposed to. It makes sense. It's kind of the same thing with the sometimes we have to crank up the x-ray machine to acquire the image. So if you look there in the anterior area, 4.7 microsieverts. Now focus field of view in the mandibular posterior, 38.3 microsieverts, which is about 6 times 6 VAs. So it is more radiation, but it's useful for the patient to understand sometimes that it's not a lot more. But look, for instance, at a chest X-ray, 170 microsieverts. It's very different. So a lot of the times they relate the Cbct scan to a medical scan. So a medical scan of their spine, for instance, is exposed the patient to 10,000 microsieverts. We're definitely, of course, thinking about the risks versus the benefits. So you have to ask yourself if this imaging that you're going to request is going to help with the diagnosis, the treatment planning, evaluation, or even with the treatment itself. And then this is another tool that you have to explain to the patient and educate the patient that it will be much easier for you, more predictable, the treatment will be more predictable, or the treatment may not even be needed depending on what you see on the Cbct scan. And the third area that they discussed in the document was interpretation. So we already discussed that all images produced must be read in their entirety, and you're responsible for that. If you don't think you're versed enough to do that, then you have to send these images to a neuromaxillofacial radiologist for reading and for a report. Different provinces may have different guidelines. In Ontario, for instance, you have to send all of the images to a neuromaxillofacial radiologist for reading and for a report. In Nova Scotia, you have to take a certification course yourself, and then you can read and do your own report. When we're learning how to interpret these images, there are certain structures that we have to learn how to interpret, and one of them is artifacts. Artifact is a structure in the reconstructed data that's not present in the object under investigation. So you see, for instance, in the image at the left, there is a upper molar that has gutta percha in the canals, and when there is gutta percha, there is a lot of scattering, so you kind of see the image is blurry, but you also see dark lines around this image, they're considered artifacts. They're not there. They're sort of a lie, but they are there, and we have to understand that they may be there, and we have to learn how to work with them. The image on the right, you see we're looking here at the premolar with the crown, and when we look at more apical area, there's a very, very lucent round area there, and then there is artifacts there that kind of look like there's a fracture there, but it's artifacts. And artifacts are usually present around an image that is very radiolucent, or radiopaque rather. And the image on the right, you see there another premolar that has good opportunity canals, and there's two dark lines there that people may think, oh, this is a fracture. No, this is an artifact that occurs around an area that's very radiopaque. So in terms of interpretation, there is a longer section in the document talking about the use of Cbct in endodontics in diagnosis, in initial treatment, in non-surgical retreatment, in surgical cases, and also in special conditions. Let's have a look at each one of them. So diagnosis. For diagnosis, intraoral radiograph is the imaging modality of choice in the evaluation of the endodontic patient. So PAs are still the primary images for diagnosis in endodontics. They may not be the sole imaging, but they are the primary. So patient comes in, we have to make to assess the patient in the case. The first thing we're doing, one of the first things that we're doing, is taking a periapical radiograph. So let's look at this case. We're looking at tooth 3-2. There's an arrow there. The tooth bothers this patient sometimes. There's a very slight discoloration of a crown. Tooth was testing negative to cold. When you look at the periapical radiograph, you see that the pulp chamber is completely calcified, and you can barely see the canal. And you can kind of see this radiolucent area there, but you also see here, is it normal bone trabeculate, or there's something that we should be concerned about there. EPT was very close to 80. Percussion was tender to percussion. Tooth responded within normal limits to palpation. You had physiological mobility, and the probing depths were below 3 millimeters. In diagnosis, limited field of view Cbct should be considered the imaging modality of choice for diagnosis in patients who present with contradictory or non-specific clinical signs and symptoms associated with untreated teeth. Okay, well, the EPT here wasn't quite 80. It wasn't responding to cold, but the canal is calcified. It was tender to percussion, and this was suspicious, so it wasn't 100% clear whether there was an issue with 232 or not. And then the Cbct, this is an older Cbct scan. It clearly showed that there was apical radiolucency present there. Not only that, but treating this tooth here with this calcified canal is extremely difficult. It is a very narrow tooth, so if you miss your alignment along the axis of the tooth, you may perforate the tooth. So the Cbct scan will help with the diagnosis, but will help with treatment as well. This paper was published in the Journal of Endodontics in 2009, and it discussed the accuracy of periapical radiography and cone beam computer tomography scans in diagnosis apical periodontitis. He also used histopathological findings as a gold standard to prove yes, it was present or not. So as a result, they found that a Cbct CBCT scan was more sensitive in detecting apical periodontitis compared with periapical radiographs, which was more likely to miss apical periodontitis when it was still present. So just some evidence to support what I just showed. Periapical radiograph was inconclusive. CBCT scan clearly showed the presence of apical periodontitis in that case of tooth 3-2. In order for, there is some conflicting evidence, recent conflicting evidence about this topic, but it's been believed that in order to visualize apical periodontitis on the radiograph, there has to be some resorption of the cortical bone so we can clearly see it on the radiograph. On the CBCT scan, that's not necessary. So bottom line, the apical periodontitis has to have a certain size to cause rupture of the cortical bone or resorption of the cortical bone so we can actually visualize it on an x-ray. There's another case to illustrate the use of diagnosis of CBCT during diagnosis. This patient fell off the stairs, and this is how she presented to the clinic. She had PFM crowns in all anterior teeth, so we knew recent trauma, perhaps this teeth wouldn't be responding properly to the tests. And although we can do cold tests in teeth that have PFM crowns, most of the time these teeth may have receded pulp chambers, and it may be a little more complicated to capture or to perform these tests or have reliable results. She was also complaining that when she touched her gums, it hurt, but she had just suffered trauma. EPT could not be done because she had the PFMs and teeth were all sensitive to percussion. Let me go to the next. There we go. And during palpation, only 2-1 was tender. All seemed to have physiological mobility and normal probing depths, but they all had bleeding or probing. But look at the condition of this tissue here. It was all inflamed. So the PA was taken, and we were kind of focusing on tooth 2-1. So again, the pulp chamber wasn't the greatest. We don't know what's underneath it, if there's even a pulp chamber there to capture the code test. So the code test, we don't, all teeth responded negative. So are all teeth necrotic, or the test isn't being reliable? So this is a sagittal view of the CBCT scan. We could see here that there's bone fracture there on the buccal side. This is why it hurt to palpation, because the bone was loose. Nothing much to do here. Maybe there is a little bit of lateral luxation. If you see perhaps the apex of the tooth used to be here and moved a little bit more buccally, but very slightly if that happened. This is a wait and see approach. There's no treatment to be done at this point, but at least we gather more information and we know why that tooth was tender to apical palpation. Another case where CBCT scan helped with diagnosis. So it is the imaging of choice when patients present with contradictory or non-specific clinical signs and symptoms associated with previously endodontically treated. So this case here is tooth 4 had been treated, apical periodontitis. So this is the post-operative radiograph. Looked pretty decent, and 2 years later the apical periodontitis increased in size. So this is the CBCT image of that tooth. We have axial view, we have the sagittal view, and have the coronal view here, and we have the 3D rendering. And if you move these lines here, the yellow, the green, and the purple, they are again coronal, axial, and sagittal lines. You can kind of move this image around and look at the 3D reconstruction. But the best way to assess these images is looking at one plane at a time. So here in the view, coronal view, you see here that there's the lesion there. Sagittal view, what do you see? That the lesion is more on the lingual side. We also see, yeah, there's a little bubble there. We don't want that, we know. But there's a little bit of sealer that went towards the lingual, and we can kind of see that there is a second canal that went to the lingual side, and it wasn't treated. The axial view here, we see a more buccal and a more lingual canal there. So the lingual canal started to be filled, and it wasn't, and enough bacteria was left behind to cause persisting of the apical periodontitis. Great, so these are great examples of how CBCT scan can help us with diagnosis in endodontics. Let's talk a little bit about treatment. So initial treatment is when the root canal treatment is being done for the first time. It's not a retreatment, it's called initial treatment. So for initial treatment, a CBCT scan should be considered the imaging modality of choice for treatment of teeth with the potential for extra canal and suspected complex morphology. This is a peg lateral. So preoperative, we may want to take a CBCT scan because look at dens and vaginatus, type 3, extremely complicated case. If this tooth is to be maintained, the best approach would be to take a CBCT scan to investigate the anatomy better. So 3D rendering here, we have the axial view here, we have the dens indenta here, and you can tell it's more buccal and more distal, and we have the sagittal view here. It's extremely complicated anatomy, but we are more prepared to do this treatment if we have this image for sure. We all know that there is MB2 most of the times in upper molars, in particular in first upper molars, and we all know that most of the time they are very difficult to locate. So very rarely we'll see MV2s in periapical radiographs. We will only see them if they're large enough to be seen on a periapical radiograph. However, we will always see them on CBCT images. So this paper here, which was also published in the Journal of Endodontics very recently, discussed the incidence of second mesobuccal canals located in the maxillary molars with the aid of cone beam computer tomography. This was a retrospective study, and they looked at endodontic treatment records from 2010 to 2014, and the number of teeth, upper molars that they looked at was 886, and they noticed that more MB2 canals were found clinically when a CBCT was taken. It was harder with full coverage crowns, well, because x-rays don't go through metal, so we won't be able to see them. And we also talked about the artifacts that are present near radiopaque structures. And CBCTs were more frequently used for retreatment cases because they are more complex cases. So this is some evidence to prove that clinically, when we take a pre-treatment CBCT in upper molars, clinicians will have a much better chance of locating MB2s. For initial treatment still, but intraoperative. So if a preoperative CBCT was not taken, the limited field of view CBCT should be considered as the imaging modality of choice for intra-appointment identification and localization of calcified canals, for instance, but for other reasons too. So look at the periapical radiograph on the left. We see here in the smaller midway in the mesial root something that's radiopaque. It's an amalgam chip. So amalgam wasn't completely removed before access opening. A piece of amalgam fell into the canal and was blocking the canal, and this is an axial view of CBCT. This is a CBCT with a larger voxel size, so it doesn't have a very good resolution, but you can clearly see the amalgam here blocking the mesiolingual canal. Can it be removed, bypassed? Not sure. It seems to be very tight in that canal. For non-surgical retreatment, limited field of view CBCT should be the imaging modality of choice when evaluating the non-healing of previous endodontic treatment to help determine the need for further treatment, such as non-surgical, surgical, or extraction. So what they're saying here is when we are looking at a tooth that already had endodontic treatment and we are assessing what's going on, CBCT is the imaging of choice. We still have to take a periapical radiograph to identify things and then determine that a CBCT is needed. But for these cases, most of the time, they are actually recommending that a CBCT be taken. Of course, clinicians will have to use their clinical judgment. These are guidelines. And if you're looking at a tooth that has a very good root canal treatment and it's failing, you don't know why it's failing, a CBCT is warranted for sure. But if you're looking at a tooth that has a very poorly done root canal treatment, this person didn't do cleaning and shaping, a person who did it previously didn't do a very good job at cleaning and shaping, the filling materials are short, or you don't see a dense mass of materials, most likely it's going to be easy to fix. Any CBCT is not needed because the reason why the treatment is failing is very clear. But if it's not, then a CBCT is warranted. So if you look at this upper molar there, see that there is mesiobuccal root, and then the palatal and the distal buccal root seem to be overlapping. There is a large lesion around the apex of the mesiobuccal root. So not 100% sure what's happening there. So the same thing here with the CBCT, we can clearly see that there is a wraparound lesion here around the mesiobuccal root. The length was okay, so why is it failing like this, right? So we kind of have the J-shaped lesion here around the mesiobuccal root. We can clearly see the distal buccal root here that was not treated. You see the canal is empty. You also see the sinus. There's some thickening here of the sinus membrane, sinus floor membrane. This is an axial view. You see this is the mesiobuccal root. The cortical bone here is gone in this area, or very thin at least. Then you see that the lesion is kind of wrapping around more the lingual side of the root. This is MB2. MB2 was missed. So when we look here at the corona view, we see MB1, MB2 was missed, and there was a little bit of a lesion there, but the lesion was wrapping around. So two things that could be happening with this case would be a vertical fracture there because of the shape, or it could be shaped like this because it was wrapping around only MB1, but MB2 that had been missed. So this case, the patient opted for a retreatment, understanding there is still a chance that the tooth was fractured. CBCT scans don't pick up fractures. CBCT scans don't pick up cracks unless they are already very dramatic. So I shouldn't say they don't. They rarely pick up fractures. They rarely pick up cracks. So what we see here, let me go back, is again bone loss patterns that may make us believe that there is a fracture. So this is showing more of the J shape that we may be suspicious, J shape that makes us suspicious, but very rarely we'll see fractures on CBCT scans. So MB1, MB2, distal buccal, and palatal. Still for non-surgical retreatment, again, it's the limited field of view CBCT should be considered when we're thinking that there is a vertical root fracture. So I got ahead of myself. We don't see fractures on CBCT scans. So a vertical root fracture starts in the root and it propagates towards the crown. Let's look at this molar here. It usually happens in teeth that are already vertical root fractures, happen in teeth that already have root canal treatments done. Small radiolucent area there. And then look at the bone here, that the bone loss, instead of being more apical, was more mid-root. Why? Probably because there was a fracture. So this bone loss pattern makes us think that there's a higher chance of a fracture there, and then we can have a better conversation with the patient. And sometimes we're much more inclined to think that there's a fracture depending on the bone loss pattern, along with other clinical findings, obviously. But sometimes we still have to do a exploratory surgery, as it's shown here, to rule out or confirm a vertical root fracture. For surgery, surgical root canal treatment, it is CBCT should be considered as the imaging modality of choice for pre-surgical treatment planning to locate root apices and to evaluate the proximity to adjacent anatomical structures. So I don't know how people do surgery without a CBCT scan, but again, CBCTs have been more popular in endodontics in the last 10 years. So if somebody who's a versed surgeon before the era of CBCT will perform really well without them. For me, I just find it extremely stressful to do surgeries without CBCT scans. So they are good because, is there a bone rupture where I know it's going to be easier for me when I'm raising my flap to see the root, or am I going to have to chase the root? So it's preparing me that way. Is it close to the sinus? Is it close to the mental foramen? Is it close to the florid nose? All of these things are important things, and to know up front, it prepares me better for the surgery. It's better for the patient. It's going to be a shorter surgery, and definitely, if I'm better prepared, the outcome will be better. It also helps me helps clinicians to take their measurements on CBCT scans. When we're measuring something on a scan, is extremely precise. It's different when we're doing this on a periapical radiograph. So let me go back, sorry. Tooth 1, 2, probably there was a, we will talk about this case later in our lecture about surgery, but a previous surgery had been done on this 1, 2 here, and it's not working. We see that there is apical periodontitis there. Thick post and crown. So this is the corona view there. We can see the size of the radiolucency better. Axial view, there's no buccal cortical bone. And kind of the tooth was cut in an odd shape there. You can see the material. We can see the material that was used there. This is a sagittal view. So there's more tooth on the lingual than there is in the buccal, because this is the way the tooth used to be cut in the past for apical surgeries. So it gives us all this information, how the tooth was cut, how much bone, do I have to chase the root here? No, because there's already rupture of the cortical bone there. It's a very short tooth, so I know I can make my measurements here and be more conservative. For lower molar surgery, or especially for lower bicuspids, we can trace the path here of the inferior alveolar nerve and where the mental foramen is, and then we're actually concerned with the mental foramen, especially if I'm doing a surgery here on the 4-5 or on the 3-5, when I have to cut, use burrs and to cut the apices or the apex of a tooth in this area here. I want to know how close it is to the mental nerve. This is the corona view. Here we see the apex of the tooth, and this is the mental foramen, and you can calculate how many millimeters you have to work with in a safe way. So we don't want to damage this nerve because patients may have paresthesia. And special conditions, trauma is one of them, where Cbct should be considered as imaging modality of choice for the diagnosis. We see here on these anterior teeth, there are some horizontal fractures here, 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 and here. We can see them. We can see both teeth are fractured, but a Cbct will show other types of fractures. So the fracture occurred right through and into the pulp on both teeth. So most likely there's a very good chance that the pulp will become compromised here. Look at how these fractures usually occur in an oblique manner, so the lingual extent of the fracture is very close to the gingival crevice, so there is a very good chance that this is going to get contaminated and this tooth will be lost. So now, because we see this, that we couldn't see on the periapical radiograph, we can have a different conversation with the patient in terms of treatment and prognosis. Resorption, so we see here tooth 2-1 has a resorptive lesion. Resorptions can be internal or external, and sometimes they are very easy to identify or determine whether they're internal or external on a periapical radiograph. But sometimes they're not. So a Cbct scan would be very useful in these cases. Also, the extent or the proximity of these lesions to the pulp, if they are external, a periapical radiograph won't give us that information. So look at this external resorption here in this lower anterior that's on the lingual side, and it's reaching the pulp. This tooth is hopeless. So it's very hard to know because we don't capture this angle on the periapical radiograph. It's very hard to know the extent of the resorption. This sagittal view, this canine, shows internal resorption, and it also shows how large it is and how thin the dentinal walls are, but this tooth still has a chance. So again, this helps us have conversation with the patient. The one in the middle is not salvageable. The one on the right is salvageable. We wouldn't be able to know for sure, or now we have a firmer prognosis for these teeth based on Cbct imaging. And that's everything. Thank you.